So you have already seen anti-epileptic drugs, and Madam has taken the drugs, that is like phenytoin, carbamazepine, valproic acid, etc. So I'll be they already we will have a just classification and mechanism of action. We will see. So this classification of this is epilepsy. There are generalized seizures, tonic-clonic, then absent seizures, then myoclonic absence, then clonic alone, tonic alone, and tonic. So such seizures are there, and we are dealing with the anti-epileptic drugs. This classification, Madam Meta already shown you. I don't know, but the classification. Let's have a look. Under barbiturates, phenobarbital, hydantoin, phenytoin, phosphonatoin, succinamide, ethosuximide, benzodiazepines, clonazepam, diazepam, lorazepam, clobazam, newer drugs, topiramate, sonisamide, levetiracetam, then primidone, then immunostimulated carbamazepine, oxcarbazepine, aliphatic carboxylic acid, valproate or valproic acid, and steroids. Then phenyltriazine, lamotrigine, cyclic GABA analogs, gabapentin, and pregabalin. So almost all the preliminary drugs Madam has taken, already taken. So now I have to tell you something. In Tripadi, there is a picture, this picture. So if you study this picture and these drugs, it is very easy to remember the mechanism of action. I'll be explaining this. So it is very easy if you study this picture and this name of the drugs. So when you study the anti-epileptic drugs, there are 4 important mechanisms. There is prolongation of sodium channel inactivation, inhibition of excitatory glutamatergic synapse. There is inhibition of the glutamine, that is formation. Then facilitation of GABA-mediated chloride channel opening, inhibition of T-type calcium current. These are the 4 important mechanisms of action of all the drugs. So if you study the drugs under the prolongation of sodium channel activation, so drugs are phenytoin, carbamazepine, valproate, lamotrigine, topiramate, sonisamide, lacosamide. Okay, so just study this. You have to by heart. If you are able to by heart this, it is very easy. Then inhibition of this glutamine, that is formation, it is inhibited by phenobarbital, phenytoin, lamotrigine, topiramate, levetiracetam, lacosamide. And facilitation of gamma-mediated chloride channel opening, barbiturates, benzodiazepine, vigabatrin, valproate, gabapentin, tiagabin, and this T-type calcium channel inhibition, calcium current inhibition by ethosuximide, valproate, and sonisamide. See, you can see this valproate, it is coming in all the group. So prolongation, here it is there, valproate is here, here also valproate, here also valproate. So valproate has all the actions. So it is the universal anti-epileptic. In any type of epilepsy, this valproate can be, it is actually useful. So please study this picture, and picture, this is very easy, only it is not complicated. So this is the sodium channel. So this is the inactivated this inactivation gate. So the drugs that is acting through this channel, it will prolong this inactivation of the sodium channel. It is actually prolonged. These are the drugs. This is number 1. Now, because I have to, because all these points will be repeated whenever when we study each drug. That is why I'm just showing now. And this. Hello.
Yes, ma'am.
Okay. You can you can see everything, no?
Yes, ma'am.
No. Someone said no?
We can see.
Okay. So the next one, it is actually this inhibition of excitatory glutamatergic synapse. We have already in the beginning of the CNS this introduction class, I have told you about AMDA, NMDA receptors, etc. So the glutamine that will be and glutamate and aspartate, it will be acting on this AMB NMDA receptors. So this glutamine, it is an excitatory this neurotransmitter. So it's if it is inhibited, that is also can inhibit the convulsions or epilepsy. So it can act as the anti-epileptic drug. So that is this mechanism, inhibition of excitatory glutamatergic synapse. Now, third one, it is about GABA. In GABA, there are different mechanisms. One mechanism, it is the benzodiazepines like this lorazepam, diazepam, clobazepam, etc. All benzodiazepines. It is acting through this receptor, and it actually increases the frequency of the chloride channel opening. That is through GABA receptor. So, so naturally, when that is opened, there is an entry of this GABA, and that will, stop the conversions. That is one. Through GABA, that is through the receptor one. The next one, this gabapentin, another drug, it will be increasing the release of GABA. So that is another mechanism. We will be telling in detail. So I'm just telling you the mechanism of action. Then another drug, that is tiagabin. There is a GABA transporters. So this the function of the GABA transporter is to reuptake. That is, it is by this transporters, it will take the GABA back into the this neuron as well as the glial cells. So this tiagabin, it will inhibit. There is inhibition of this transporter, so that all the GABA will be in the synapse itself. There is third mechanism. And the fourth mechanism, it is an enzyme called GABA transaminase, GABAT transaminase. So this GABA transaminase actually causes the metabolism of GABA and causes the reduction of GABA. So, but if it is inhibited, then the level of GABA can be increased. So we need GABA to control seizures. So these are the different mechanisms. So it is very easy. So this picture, it is not that complicated. So here itself, all the drug name, it is written also, so you can study. Now, the fourth one, usually the T-type or the T means it may be transient or thalamic. So because of the calcium current in the thalamic neurons, actually it is a reason for absent seizures. So if that is inhibited, certain drugs like edoxaximide, valproate, sonizumab, etc., it will inhibit the C-type calcium current. So these are the drugs mainly. So those drugs which will inhibit the T-type calcium current, they are mainly for the absent seizures. Because in absent seizures, the main problem is the excessive calcium current through the T-type, thalamic type, or the transient type calcium. So these are the only drugs that is used for the absence. Some drugs are also there, but main drugs, edoxaximide, valproate. So I have already told valproate, it is the universal anti-epileptic drugs. In everywhere, valproate is there. So please study this. Then is again another one more thing. There is SV2A, means it is a synaptic vesicular protein. That is SV2A. This is also one drug is there. We will come to that. It will be acting on this synaptic vesicular protein and inhibit the release of glutamine. So glutamate and aspartate. So especially glutamate. So these are certain drugs. So these drugs will be acting here. Okay, now we will come to the drugs in detail. So now you know all the mechanism of action. Now it is easy. So when I say it is okay, this again I have told GABA. Effectiveness is by benzodiazepine topramate. GABA agonist, that is increasing the release. That is gabapentin. One drug called N-carbil, it is the extended release. Then one analog, it is pregabalin. Then transaminase inhibitor vigabatrin, reuptake inhibitor tiagabin, and GABA SV2A, that is levetiracetam. Okay, we will come one by one all the drugs. So clonazepam, lorazepam, clobazam, diazepam, all these are benzodiazepines. So what is the action of benzodiazepine? It will cause the increased frequency of the chloride channel and increases the entry of this GABA and its action. So benzodiazepines potentiate GABA-induced chloride influx into to produce sedation. So all this, benzodiazepine, it causes sedation. So whenever there is GABA, there may be sedation. And so that is but it is not all these benzodiazepines, we cannot take it as a monotherapy for epilepsy. It is combined with other drugs, but we will see that. Then clobazam, another benzodiazepine, same effect. It will open this chloride channel, that is an entry of the increases the frequency of chloride channel opening. This clobazam, it is 1,5 benzodiazepine. All other benzodiazepines, it is diazepam, etc. It is 1,4. So the action is facilitating. So it is very easy. So if you study that picture, it is very easy. And so that is the sedation. All the benzodiazepine, the side effect, if you think it will be sedation, psychomotor retardation, etc. Now, diazepam. This is the common drug, the diazepam, again benzodiazepine. So this also, it increases the frequency of the GABA channel, that is a chloride channel opening. And but it is not used for long-term therapy. I have told already, because it is having sedative effect as well as development of tolerance. After some time, its effect may vanish. So it is not for long-term therapy, but it is used for the emergency control of convulsions in status epilepticus. We will see that tetanus, eclampsia, convulsion, drug poisoning, etc. We can see that. Then this dose, better you study, it is 0.2 to 0.3 milligram per kilogram IV injection, followed by small repeated doses, and maximum 100 milligram. Then some side effects like thrombophlebitis, then marked fall in BP, there is BP fall and respiratory depression. Always benzodiazepines, always whenever you think of benzodiazepines, two side effects, that is sedation, respiratory depression, that will be there. So you have to be very careful whenever you are administering this drug also, you have to be careful. Then if IV injection, if it is not available, then we can give rectal installation of diazepam. Solutions are available, or this IV injection, that ampule itself, we can cut open, and that can be given rectally also. So that is, it is especially in case of children with febrile convulsion. We will come to that. Lorazepam, another benzodiazepine. So this is the best suited in status epilepticus because the side effects are less. Thrombophlebitis, it is less and more sustained action. Because diazepam, it is when we give diazepam, because it is highly lipid soluble, it will be distributed, and so after some time its action will fade off. But lorazepam, it is not that much distributed, so it is having more sustained action and less local thrombophlebitis, because that is why it is best suited in status epilepticus. Next drug, lamotrigine. Lamotrigine, where comes lamotrigine? We will see where is there. Lamotrigine, it is here. Here also it is there. It is not there. So the lamotrigine, if you see this picture, so it has got two actions: sodium channel inactivation and inhibition of excitatory glutamatergic synapse. So we will see what is lamotrigine. So this lamotrigine, it is prolongation of the sodium channel inactivation, directly block the voltage sensitive sodium channels. This is for explaining. And also prevent the release of excitatory neurotransmitters like glutamate and aspartate. Okay, that is evident from that picture. Okay, so that is why I told you to study that picture. So it inhibits it prolongs the sodium channel inactivation and also inhibit the release of this glutamate. So because we have already seen in my introduction class that glutamate only causes the excitotoxicity. So because of the action on the AMB and NMDA receptors, so that is actually inhibited by lamotrigine. Then whenever we think of this anti-epileptic drugs, some of the side effects we can just write like this. I mean, it is there: sleepiness, dizziness, diplopia, ataxia, vomiting, etc. But this lamotrigine, one adverse effect, important adverse effect is rash. Rashes can occur, especially almost all anti-epileptic drugs. When you begin the drugs, people may develop a rash. And for lamotrigine, rash is one of the serious reaction. So especially in children, it may cause. So that is lamotrigine. So we have seen that. Now, gabapentin. Okay, we will see where is gabapentin. Gabapentin, it is not here, it is here. Okay. So we have seen that gabapentin, this is gabapentin. So it actually facilitates the release of, it is like a GABA agonist. So we will see gabapentin, it is a lipophilic GABA derivative, crosses to the brain and enhance the GABA release. And its congener, it is called the pregabalin. Then there is another the study that is also act on the voltage sensitive calcium channel and reduce the glutamate release. But this is more prominent action, so it is not confirmed whether it is by the glutamate release or GABA release. But you can just the first you can say it is the enhance the GABA release, and it is mainly used for the neuropathic pain. So this is a first-line drug for the neuralgic pain due to diabetic neuropathy. If you are having some, if in your house itself, your relatives or parents or anyone who are having this diabetes, and if you are developing, they are developing neuropathic pain, diabetic neuropathy. That is, they'll be once the after a few years of this diabetes, people will develop neuropathy or neuralgic pain. So such cases, this is the best drug, gabapentin. You can start with 100 milligram, then it can increase up to 300, 600, etc. So such people, they will be having better relief with gabapentin. It is also a prophylaxis for migraine and phobic conditions, this gabapentin. Yes, the side effects I told you, sedation, tiredness, dizziness, etc. can occur. Pregabalin, it is a congener of gabapentin. It's also used in case of, this is also commonly used for neuropathic pain, diabetic neuropathy, post-herpetic neuralgia, then complex regional pain syndrome, chronic pain, some types of chronic pain. Especially it is used in case of diabetic neuropathy. Then rashes and allergic reactions can occur. Almost all antiepileptic drugs in the beginning, they may develop rashes. Then levetiracetam. Levetiracetam, see where is it? Levetiracetam. Levetiracetam, it is here. Yes. So levetiracetam, what does it do? It inhibits the glutamate. So it binds selectively to a synaptic vesicular protein, SV2A, and alter the release of glutamate and also GABA across the synapse, thereby exerting anti-seizure effect. And it also inhibits the end calcium channel. Okay, we will see this alone. So SV2A. So we have, sorry. So I have told you synaptic vesicular protein. So here it will be acting and inhibit the release of glutamate. So we are having this levetiracetam here. And the side effects, it is like dizziness, sleepiness, etc., etc. And but it is not approved for use in children below 4 years, and it is free of drug interaction also. Levetiracetam, one of the commonly used drug. So it is then topiramate. Topiramate, we will see where is topiramate come. Sorry, topiramate here. It is here. Topiramate. Here also topiramate. Anywhere else? No. So the actions are sodium channel inactivation and this excitatory glutamatergic synapse, that is inhibition. So this is topiramate. Topiramate. So it is a carbonic anhydrase inhibitor and it is having multiple mechanisms. That is, we have seen that prolongation of the sodium channel inactivation and suppression of the neuronal firing, and also antagonism of certain glutamate receptors. In addition, where it is not shown there is hyperpolarization through potassium channels also. So multiple mechanisms are there for topiramate. And so because of this mechanism, it can be used as monotherapy also. Then adverse effects like sedation, ataxia, word finding difficulties, poor memory, weight loss. So sedation, ataxia, all these things are there for all the drugs. So that was for topiramate. Now sonisamide. Where is sonisamide coming? Sonisamide. It is here. So it is having sodium channel inactivation, prolongation, and also where else it is here. It is acting on the T type. So sonisamide can be used in case of absent seizures also. So all these drugs are not used for absent seizures. Sonisamide, it is sonisamide. So two actions. So we will see sonisamide. It's a newer anticonvulsant, anticonvulsant, and it is a weak carbonic anhydrase inhibitor, prolongation of sodium channel activation, and also suppress the T type of calcium. So you have seen in the picture. So please study that picture. It is easy to write everything. And the side effects will be dizziness, headache, all these things are common. Then one important point about sonisamide, it should be avoided in patients sensitive to sulfonamide. So it is, see, all these are amide. So sulfa-containing. So sonisamide should not be given in patients who are sensitive to sulfonamides. Then lacosamide. Lacosamide, where is coming lacosamide? Lacosamide, it is sodium channel inactivation. This glutamate here is there. No, not here. Okay, so it is two actions. So, but it is only an add-on therapy. So it enhances the sodium channel inactivation, suppression the repetitive firing. And in addition, there will be a glutamate release also. It's not given in the book, but it is there. Hello? Are you all there?
Yes, ma'am.
Okay, because my internet, there is some problem. That is why in between I am asking you. Okay. Then the adverse effects: ataxia, vertigo, diplopia, then tremor, depression, and cardiac arrest. So lacosamide. So the mechanism you have seen. No. Okay. Now tiagabin. Where is tiagabin? Yes, it is here. Tiagabin. Anywhere else? No. Tiagabin, it is not there, only here. What does tiagabin do? So the tia, where it is written as tia. This is tiagabin. So the transporter. So it will inhibit the reuptake of GABA into the neurons as well as into the glial cell. So that is the action of tiagabin. Inhibit the reuptake so that GABA will be available here, the synapse. So we will see what is tiagabin. Neuron anticonvulsant potentiate the GABA-mediated neuronal inhibition by blocking the GABA transporter, that is GAT1, which removes synaptically released GABA into neurons and glial cells. So into the glial cells as well as the neurons, it is inhibition. So by inhibiting the transporter, that is tiagabin. Then vigabatrin. It is a GABA vinyl GABA. So it is here, this is the, so where is this GABA? Vigabatrin, this is Viga. So there is the transaminase. So this enzyme is inhibited so that the metabolism of GABA does not happen. So there will be excess of enough GABA will be available. That is vigabatrin. So it is an inhibitor of GABA transaminase enzyme which degrades the GABA. So inhibits the enzyme which degrades GABA. This vigabatrin, a visual field contraction and alteration of color vision. This is one important side effect. So vigabatrin, visual field. So we have to check the in between. They have to undergo ophthalmologic, monitoring. That is vigabatrin, and it can also cause alteration of color vision and paresthesia. So that was all about the drugs. Then, if you are those who are interested to go for PG and for the entrance examination later, some newer drugs are there. Rufinamide, then that is a slow sodium channel inactivation. It is a latest drug. Then ezogabin, it is a potassium channel facilitator. Then perambanel, it is a non-competitive antagonist of AMBA receptors. Again, that is through the glutamate. So these are certain latest drugs: rufinamide, ezogabin, and perambanel. Okay. So we have seen all the drugs for epilepsy. Now we will see how to treat epilepsy. So the treatment of epilepsies. We have all the drugs with us. Now we are going to treat epilepsy. So as you all know, this anti-epileptic drugs only suppress the seizures. They won't give any cure for the disorder. And so what is the aim of the treatment is actually only controlling and preventing the seizure activity. So, and we have to find out the cause of epilepsy. Sometimes it may not be a simple epilepsy, that is idiopathic epilepsy, but it can be of a different reason. It may be of different infections or some injuries or some tumors. So we have to find out what is the reason for this epilepsy, and that reason, if it is there, some pathology is there, some reason is there, that has to be removed, number one. Then we have to go for the treatment. Now, what are the general principles of symptomatic treatment? Suppose we confirm that it is an epilepsy, it is a GTCS or petit mal or any partial or complex partial seizure. We have found out that. So, how will you treat the patient? So, the choice of drug and dose, these points are important. The drug and dose, it should be according to the seizure types and need of the individual patient. So we cannot give a drug that is given for the absent seizures to a patient with GTCS, that is generalized tonic-clonic seizures. So we have to find out which drug should be given. That is number one. Number two, always start the treatment early, because each seizure episode increases the propensity to further attacks. So it is like it is akin to kindling. Kindling means that is we are just giving a burn here or fire here, and it will go like that. So it will finally it will become a big seizure. So that is a kindling. So we have to start early. The treatment has to start early, and always start with a single drug with low dose, and gradually we have to increase the dose. And sometimes with a single drug, the seizure may be controlled. And if and we have to gradually only increase the dose. And there will be full control of seizure. Sometimes after some time, the patient may develop some side effects also. We have to see that. Suppose with a single drug, if full control is not obtained, then we have to substitute another drug. So with one drug, it is not happening. So we have to give another drug. Then we have to do something. The first drug, we have to gradually only remove it. I mean, reduce the dose gradually and remove it. And we have to add the drug at the same time. And you have to gradually increase the dose of the second drug. So that we should not remove stop the drug, first drug immediately and start the second drug. So that is very important, because it will take some time for the action of the drug. So we have to taper the first drug and gradually and start the second drug and gradually increase the dose of the second drug. And when monotherapy fails, we have to go for combinations. And all these phenytoin, etc., they are having only very low therapeutic range. So we have to do always the therapeutic drug monitoring. Okay. Suppose a patient is having a single tonic-clonic seizure, and then you don't have to start the treatment. But what we have to do is, as I have already told in the beginning, you have to find out, is there any reason for this tonic-clonic seizure? And if there is only, and you don't find any reason, any etiology for the seizure, and if so, and if there is only one clonic seizure, we can just wait and see. And but if it is recurring, means immediately you have to start the treatment. Single episode means once it happened and after that never occurred, then no need of any anti-epileptic drugs, because all these drugs are having side effects also. So, but at the same time, if it recurs once or twice, then we have to start early. I mean, twice or thrice, we have to start immediately. So I was telling we have to see the choice of the anti-seizure. This is also from your book, Tripadi. So we have to, in all cases, we have to see which drug should be dosed. So the only three things we will see: generalized seizures, that is tonic-clonic seizures. Any seizure we can use this valproate, lamotrigine, and carbamazepine. Absent seizures, it is valproate and ethosuximide. And also we have seen sonizumab also effective. Then febrile seizures, always diazepam. It is rectal. Status epilepticus, it is lorazepam. It is number one drug. Immediately we'll come to that. That it is better than diazepam because diazepam, I told you, because of the more distribution, its action may there is a vanish after some time. So lorazepam of less distribution, it is having sustained action. So that is the this is the based on the choice of anti-seizure drugs, you have to select it. Now, the therapeutic regimen should be simple. We should not give all drugs, all the new drugs, everything. So we should not make it so complicated. And you have to ask the patient to keep a seizure diary. Because this is because we have to see whether he's taking the treatment. If he's not taking the treatment, chances of recurrence is there. And as a rule, once if there is epilepsy, if you start a treatment, at least for 3 to 5 years, it should be continued. After that, only it should be tapered and stopped. So all the drug withdrawals should be gradual. Then stoppage of the therapy should be attempted only in selected cases also. Then suppose a woman, that is who is pregnant women, women on anti-epileptic therapy, they are becoming, they conceived. So what should we do? We should not stop the anti-epileptic drugs because anti-epileptic drugs, if you discontinue, there will be higher risk of status epilepticus and the baby may die. So that is number one. But with the drugs, some disadvantages will be there. But if you avoid drugs like valproate, because valproate can cause the spina bifida and other birth defects, so better change to some other drug. But don't stop the anti-epileptic drugs. And in addition, we have to give prophylactic folic acid supplementation in the second and third trimester, along with vitamin K in the last month of pregnancy. This vitamin K is given, it is to prevent bleeding, and folic acid, it is to prevent the neural tube defects. So, so nowadays, even if they are not on anti-epileptic drugs also, the antenatal checkup, they are giving folic acid, but if they are not giving folic acid, it should be there if the person is on anti-epileptic drugs. So folic acid as well as vitamin K. Then, so suppose there is during an attack of tonic-clonic seizures, what should we do? So our idea is to see, suppose in our family or in our neighborhood, suppose a person is having this tonic-clonic seizure, suddenly one person is getting the seizure, and we should not be, we should not worry or we should not become panicky. So what we have to do is we have to prevent injury. Anyway, that person will fall down. So always see that he or she should be in the lateral position, whether it is right lateral or left lateral. This is for, and also the chin should be up like this. That is chin up and head tilted like that, so that the airway will be patent. And another thing, there will be frothing and salivation, etc. So it will drool out. And if they vomit also, it will come out. But if they are just in the supine position, this may interfere with their, breathing, and it may stop breathing also. So there will be aspiration also. So for that, always keep the person in the lateral position or prone position. That is lying on the prone position. So this is the position, and no need of, if possible, you can keep some cloth, there is folded cloth you can keep in between the tongue so that they won't bite the tongue. So, but it should not push inside, only to prevent the, in between the teeth only. So like this, you can keep the, and because all the, most of the epilepsies, they are like GTCS, that will, it will stop after some 2 to 3 minutes. So, but even after that, a patient will be having some post-epileptic, that is some sedation or only after some 15 to 20 minutes, they will be completely normal. So these are the things we have done. Then we have to give the treatment. So I was just telling, during the attack of tonic-clonic seizure, what should we do? Then another point, another conversion, it is febrile conversion. Febrile conversion. Febrile means, what is febrile? What is the meaning of febrile? Hello?
Temperature.
Yes, fever. So those are having the children usually under 5 years of I mean up to 5 years. There is some children, they may develop convulsions during fever. When they develop fever, they may develop convulsions. So this is called febrile convulsion. Febrile means with fever. So what is the treatment? So fever means what is the drug we have to give for fever? Hello.
NSAID.
Which NSAID we will give for
Paracetamol.
paracetamol? Yes, we can give paracetamol. So we have to immediately, better you control the fever, and you can give the external cooling, that is tepid sponging we have to do. And if the seizures are recurring every time with fever, we have to give this rectal diazepam, 0.5 milligram per kilogram we can give. And this is in some preparation. I mean, the solutions are available. I think in India, I don't know whether it is available, but in foreign countries, the solutions are available. And or you can take the IV preparation that can be taken for rectal instillation. So that is the rectal diazepam we have to, and it should be repeated 12 hourly for 4 doses. If we are giving in the morning, evening we have to give, and like that 2 days, 4 doses we have to give. But the problem is the children, usually this febrile convulsions, it can happen at any time less than, I mean, up to 5 years or maximum up to 6 years. But after 6 years, if it continues, then we cannot take it as a febrile convulsion. It should be taken as, treated as an epilepsy case. So up to 6 years, it is nothing to worry. It is just a febrile convulsion only. But each time the convulsion occurs, there is actually, whenever there is convulsion, there is something anoxia to the brain, isn't it? So we have to prevent it. So for this, we can give either diazepam, but nowadays the pediatricians, they give clobazam. It is another benzodiazepine, and it can be given. There is clobazam, usually like this. This is the treatment that is given in nowadays Indian pediatrics. That is less than 10 kg means clobazam, we can give 5 milligram, morning half, night half for 3 days. And if it is more than 10 kg, that is the weight of the child, the clobazam 5 milligram, 3/4 into 3 days. Then there is also a spray called midazolam. The spray also can be at the time of convulsion, we can put the spray also. This clobazam, we are giving only for 3 days. Suppose the fever, it persists for some 6 or 7 days. We should not give like that for 6 or 7 days. We can give for 3 days. Then we wait for 24 to 48 hours. Still the fever is continuing. We can again repeat the dose like that. Otherwise, no need. After 3 days, if there is no fever, to continue it. Only 3 days we require. And up to 5 days, it is okay. After 5 days, again fever means we have to repeat this. And also we can use this midazolam spray. Then another condition called infantile spasm. Here there is a condition that not much. It is antiepileptic drugs are useless. We can corticosteroids, then clonazepam, valproate, and vigabatrin. It may be of some use. Okay, this is not that important. Then the most important, that is the status epilepticus. What is status epilepticus? So when the seizure activity occurs for more than 30 minutes, usually normally the GTCS, it will last only for some 5 minutes. But the seizure activity, if it occurs more than 30 minutes, or 2 or more seizures occur without recovery of consciousness. So in between, the person is not becoming conscious. It is called status epilepticus. So it is, as you know, it is an emergency because there is anoxia to the brain. So we have to immediately we have to treat, otherwise the person may die and there will be permanent brain damage also. So immediately the first and foremost thing is we have to do the ABC. What is ABC?
Airway breathing.
Airway, breathing, and
Circulation.
Circulation. So all these things. So I have told you, I have shown you the picture. So the person should be his airway should be patent, and you have to see whether his circulation is. I mean the BP pulse, everything is okay. So all these things it has to be done within seconds. Seconds. Then only it is so fast. Our action should be so fast, and then we can give 50% dextrose, because we don't know whether the person is developing this epilepsy because of hypoglycemia. Hypoglycemia also can cause convulsion. So we can give immediately 50% dextrose. If it is due to hypoglycemia, immediately he will recover. But if it is, and even otherwise, if it is not due to hypoglycemia also, if we are giving 50% dextrose, it won't cause any damage. The number one drug, that is the lorazepam. It has to be given this dose, and it's all these drugs you have to study. Status epilepticus is very important. It is one of the important questions for your university as well as in the management, in the clinical side. It is very important. Lorazepam 4 milligram injected IV. Then it has to be repeated after 10 minutes if it is not controlled. So first of all, we have to give the status, the epilepsy, it is continuing. So immediately you are giving lorazepam. First you have to give dextrose, then lorazepam immediately. And after that, we have to give fosphenytoin. So, but there will be continuous ECG monitoring, 100 to 150 milligram per minute. See, this after lorazepam, anyway, you have to give fosphenytoin. We are not seeing whether the epilepsy is controlled with lorazepam or not. We are not saying. We are giving fosphenytoin. And fosphenytoin is the preferred drug now. Phenytoin sodium we can give when fosphenytoin is not available. So number one, lorazepam. Number two, fosphenytoin we have to give. Now, because phenytoin sodium has got local vascular complications. Then if fosphenytoin is not available, or phenytoin is not available, we can give phenobarbital sodium 50 to 100 milligram per minute. Now, refractory cases. So after giving all this lorazepam, fosphenytoin, etc., it is not controlled. So still the epilepsy is continuing. So we have to go for IV midazolam. It's a benzodiazepine, propofol, anesthetic, thiopentone anesthesia, anything you can give, but without curvarization. That means we are not using any skeletal muscle relaxants, and it should be under full intensive care. So this is the treatment of status epilepticus. In addition, all the general measures that intubation if needed, maintenance of airway, oxygen, then IV fluid, then we have to keep the BP under control. I mean, it should not go very low. No, the cardiac rhythm should be normal. Then in between, we have to check the blood glucose. It should be euglycemic. And care of the unconscious. People will be unconscious and so they don't know anything. So we have to take care of the unconscious state of the this patient also. So that is so we have to give first lorazepam, followed by fosphenytoin. Then fosphenytoin, if it is not available, phenytoin or phenobarbital. Then refractory cases, IV midazolam or it is not or propofol or thiopentone anesthesia, and the general measures. I think that was the last slide. Yes, thank you.